Patients with microcornea and typical iris coloboma are not uncommon, and these patients have a typical problem of early onset cataract and also risk for detachment. This is one patient in whom the patient had bilateral microcornea, microphthalmos, and coloboma. And here we will see how we manage this case. This is the anterior segment photograph of the eye, and the photograph is not very good quality because patient had photophobia, nystagmus, and all those problems which are associated with this condition. This is the point where we are trying to start the surgery, and for this cataract, which as we can see here, the patient was planned for surgery. And this is a really small eye, and as we can see, the cornea is hardly 6 millimeters in diameter, and the plan was to not only remove this cataract but also to implant an IOL. Now this will surprise you. An IOL in such a small eye, is it a customized IOL or is it a regular IOL? And we will just see that. Now opening the conjunctiva was helpful because you could see the limbus extended beyond the border of the conjunctival adhesion. And here making a phaco entry, and we can see the blade, which is 2.8 millimeters, is nearly filling up this cornea. Now making a capsulorhexis is challenging in this situation, so the capsule was stained, and as you can see the flap being propagated and the rhexis being executed slowly with repeated replenishing with viscoelastic, because the anterior chamber was very shallow, and any amount of viscoelastic material which leaked out caused the shallowing of the anterior chamber. The shallowing of the anterior chamber is not desirable because that would allow the capsulorhexis to run out and losing control of the capsule. So here we can see the capsulorhexis has been completed. It's a small rhexis, and now the time to remove the cataract. Because this patient was relatively young, so I was assuming that this patient may not be having any significant nuclear sclerosis, so this will come out just by irrigation aspiration. But as we can see, it has a significant nucleus and only the overlying cortex can be aspirated out. So once the nucleus has been bared, it's time to go for a phaco. And here we can appreciate that how big the phaco tip appears in this eye. I didn't make a side port because it was obvious that side port will allow some leakage and there will not be much leverage because of the small size of the eye and the anterior chamber. So the plan was to do the phacoemulsification in steps, and once we have achieved a deep crevice, we will switch to using the same port to rotate and divide the nucleus. So this was like phacoemulsification, which is standard technique, is bimanual, being done with one hand using one port and completing the steps in sequence. So once the crack or the groove has been made, it was time to again further sculpt the nucleus so that it becomes amenable for removal. The anterior chamber was shallow, the capsular bag was rather large, and in these situations or in these patients, you will be surprised that the size of the bag and the cataract, that is the crystalline lens, would not be as small as you can see. So these capsular bags extend well beyond the visible limbus. So doing it very gradually, very slowly, taking caution, the zonules also may be missing and weak at points. So trying to rotate this nucleus or rather break it into pieces so that it can be removed using phacoemulsification. So this requires a lot of patience, and only then you can be able to manage these cataracts well. Preserving the capsular bag is so important here because that is the only feasible site where you would be able to implant a intraocular lens. There is no possibility of any iris fixation or angle supported IOLs or any scleral fixated IOLs. One has to have an intact capsular bag if there is any possibility implanting the IOL. Here we can see a part of the nucleus was prolapsed out, and we are able to now gradually remove portion of the nucleus. This process will continue till we can see that whole of the nucleus has been removed. So it's something like a slow motion phaco using only one port. This surgery is being done under local anesthesia because patient would not have a stable eye, because these patients have nystagmoid movements, and in spite of all their efforts they are not able to keep the eye fixed into a position. So local anesthesia, that is retrobulbar or peribulbar anesthesia, is what is required. Once the nucleus has been disturbed and broken into pieces, it came out easily. Now filling the anterior chamber with viscoelastic and also putting some viscoelastic behind the epinucleus so that it prolapses into the anterior chamber, and now removing the epinucleus and the cortex. This is again a very deliberate, slow, purposeful movement because the capsulorhexis is small, and the small capsulorhexis will always hinder into the smooth removal of cortex, and one also has to take care that the capsule is not disturbed or pulled, because that will compromise the integrity and stability of the capsular bag into which we are planning to implant a intraocular lens. Now subincisional cortex is very tricky because there is hardly any leverage which we can get by rotating the tip. The chamber is very shallow, it will inadvertently catch the posterior capsule and we will have a disturbed capsular bag. So in such a scenario, one has to resort to making another port which will be diametrically opposite the area where the cortex is still remaining. That would be the safest bid, or else one can go for bimanual irrigation aspiration, which may be an option for these eyes which have very small anterior chamber. So putting in irrigation so as to make the eyeball turgid and going in for another incision nearly opposite side and using a Simcoe cannula which would go inside through the smaller port, and this will not require a full size port as would be required by a standard irrigation aspiration cannula of the phaco machine. However, this angle or this approach provides a nice access to the cortex which is lying directly ahead, and one can simply reach out to the cortex and remove every bit of it. As we can see, this cortex is being engaged and removed. Once the capsular bag is empty, it is time to implant the intraocular lens. But how to accommodate a standard IOL in these eyes? So the trick is you cut a part of the haptic, and the optic which is 6 mm in size, which will be accommodated with these haptics which have been cut off, partly making it little weak so that they are folded well inside the bag. Full size IOL cannot be accommodated in these eyes, and one has to use this trick. So this is how you use a Rayner design of lens and trim the outer rim of the haptics so that only a very thin and very soft part of the haptic remains. This is one trick which I have been using to implant IOLs in these small colobomatous eyes, which I operate very frequently. So now, as we can see, the haptics have been trimmed so that the overall diameter of the IOL is smaller, and which will go inside the bag and will be fitting the bag with no undue stretching of the bag or vaulting of the IOL caused by the limited space in the bag. This is the leading haptic, and there goes the optic, and now we have to dial the trailing haptic. The details are not clear, but as you can see, the IOL goes into the bag underneath the capsular rhexis, and the rhexis is little bit stretched right moment. However, the capsule is elastic enough that the trailing haptic can be dialed into the bag without causing much disturbance. Using the inferior port may help here, but in any situation one has to keep the anterior chamber inflated, otherwise the IOL will prolapse up. This port will provide better leverage to rotate the IOL and also to push the trailing haptic into the bag, which now goes well into the bag, and we can see this is the post-op picture, day 7. There is some amount of corneal edema, but the IOL is stable, and as in the earlier photograph, because the eye is not stable, so the photograph is of low quality. But this is how we could implant an IOL in such a small eye. Thank you.